So today we're going to be going over geriatrics. You will notice that we've gone over the majority of this prior to in most of the other subjects, whether it be medical trauma, and this is just focusing on the specialty population that is geriatrics. So we will be just kind of reviewing this. It'll be very quick in class, and in here I'll try and be a little bit more in depth for this the recorded lecture. But still, a lot of this is just review and just kind of focusing on some of the things that are different specifically with geriatrics compared to the normal populations. So from here we will go start this relatively long slideshow. So when we look at geriatrics, as many of us who have worked in the field recently or ever have noticed that geriatrics take up a rather large portion of the population that we deal with in EMS, and that age group is getting larger and larger as people are living longer and longer. So we can kind of see here's some of the actual specific numbers that are out there. Just in a nutshell, there's going to be a larger and larger percentage of geriatric patients that we're going to have to be dealing with, and just geriatric people in general, as we all hopefully get older as well. So we know that they have more comorbidities typically, and we're going to go over a lot of that. And they have a lot going on, so we need to make sure that we're there to be able to take care of it. So there's also a number of interesting issues that we have to deal with that we don't typically have to deal with our normal populations. And one of those is a big example would be the advanced directives, durable powers attorneys, DNRs or do not resuscitate orders, and then or post and a physician order for life-sustaining treatment. And so we'll go over some of these. I actually have some examples of what we can see locally, and we'll try and look at some of this and deal with what we need to do when we're presented with this paperwork too. And this is actually a interesting part, and we'll probably talk about a bit about this in class because this is one part that it's good to try and figure out if there's any questions and deal with that, because it is an issue that we have to deal with when we get presented with DNRs, or they said they have one but they can't find it. Things like that, and we'll start going over some of that. So here is our DNR protocol for Southern Nevada Health District, and it follows very, very closely to the Nevada state guidelines. If anything, with anything, it'll just be more strict as opposed to more lenient from Nevada. Being said, here's our exact protocol and what we need to look for when we get that. So obviously this is not one where we're dealing with conclusive signs of death, but when either they're gonna code, they hard coding, or it looks like they might en route, and we need to have this conversation with the patient and or family. And these are the things that they need to be giving to us for pieces of identification and their DNR. So different types of DNR identification include the form itself, a wallet card, a medallion issued by Southern Nevada Health District. I haven't been able to find one, but I'll see if I can find one here soon for class to show you guys an example. Or if it could be another state and we can't accept that if it isn't official. If you have questions, you can always call for orders, or try and look it up to see if that looks like an appropriate one from a different state. As far as like medallions and stuff go, that we used to not accept medallions, but now we do. So it doesn't count if someone has it tattooed across the chest DNR. You might want to ask someone, hey, do they have an official DNR? No, then we still have to work on, right? The other thing we can look for is just a DNR order written with it is a written directive by the physician licensed in the state that life-sustaining treatments not to be administered to a patient. So with that, and then the last one, the post, and it tells them what type of healthcare they want. Sometimes it's a DNI, which is do not intubate. Sometimes it's DNR. Some of them can be kind of complicated. We'll look at the pink sheet here in a minute as far as the state of Nevada goes on what they're really looking for. And when you look at it, it'll have sometimes very specific directions. It'll say, hey, go ahead and give me medications. Just don't give me uh, chest compressions or intubate. There's a number of different things that they'll have on there, and they can check on that book. Remember, verbal instructions from friends or family do not. The only exception from a family member would be is if they are the medical power of attorney. Then there is some, or then they are able to. Being said, if you have any questions, always get on the line to doc if there's any questions at all, and we can figure it out then. We do want to be respectful for people at the end of their life. We don't want to just work them and keep them in a vegetable state or do DNR when they want to be peaceful to pass with their family. So if you have questions, either start working or get a hold of a doc trying to figure out the situation. That's usually the best way to kind of start that process. And just try your best to is kind of look down that we are, if you're presented one and if it's any type of question, we'll try and make sure it seems valid. Once again, most of the time there shouldn't be many times where it's not a valid and people are trying to withhold care for their family. Most of the time it's the family's wish and they want to kind of pass with their family at home or just not have to go through the whole process and add hospital bills for something that they're not going to get anything out of. So with that, we do supportive care, and supportive care is really important, guys. Some of the things, if they're still with us and they haven't coded, pain management's huge. Oxygen is not an invasive. Now, for whatever reason they don't want oxygen, that's fine. But if they're a little bit out of it, just do some non-invasive things. I know pain medication can be kind of invasive. Usually IVs aren't a big thing. If they have orders that say they don't want them, cool. But many times that the pain medication can really help them pass them. Not to say you're going to make them pass by giving them too much pain medication, but just to make, particularly end of life and cancer patients, they're in a ton of pain anyways. Let's try and help them. And one last thing, faxed, copied, or electronic versions of DNR or Pulse are legal and valid. So if they have that and everything looks legit, but it's a copied, faxed, or electronic version, it is accepted. And then we'll talk about some quick supportive care stuff we can do as well. So different types of supportive care that we can provide, you can specifically through Southern Red Health District, even if they have full DNR, and unless there's something on there specifically that says they don't want this one thing done. Suctioning the airway is pretty big. You know, if you think about it, drowning on your own in your own airway or from your own saliva sounds pretty horrible and doesn't sound like a pleasant way to go. So suctioning the airway, not being invasive with it, not doing deep suctioning, anything like that, but just going about trying to help them out some, giving them oxygen, positions of comfort, splinting anything if they fell, controlling any type of bleeding. TNRs typically don't account for traumatic injuries involved, as when we even talk about hospice here in a minute too. Very similar. Like if it's not necessarily related to their end of life care, let's try and support them. Pain medication is a big one. We can help them out a lot with that. Let's get some pain meds on. Morphine's fantastic for this. It has that narcotic sedative effect that really kind of snows them out a little bit and can really help them out. Emotional support, and then hospice if they're in hospice, or getting social work involved too. And sometimes, even if the patient themselves is dying, we still need to support the family, even though they might be prepared for it. It's still a pretty traumatic experience, and sometimes emotions get high, and you never know, you might end up transporting one of those. People have all types of issues like that. So, different things we can look at. So when we look at different types that they can decide to withhold from as far as resuscitative treatment itself, normally we just think of CPR and intubation, but here's some of the things that they can check yes or no on the very specific. Maybe they want they're okay with being intubated, but they don't want chest compressions done. There's a number of different things that we can kind of look at it there. Defibrillation, maybe they want chest compressions, but no defibrillations. We know that usually not going to be that effective. However, maybe the family member wants that, or the patient wants it. Cardioversion, assisted ventilation, whether that's invasive or not. They can have non-invasive ventilation assistant is okay, but no intubation. There's there's a number of things they can do, and then as well as maybe they don't want any drugs, but they're okay with CPR or vice versa. So they can have any or none of these checked, and you just have to try and see. And if you have any questions, you can ask family members or go ahead and call a doc. Here's a sheet of the Nevada Pulse itself, and as you can kind of look at there and get a and go down there, you can see all the different types of things they would like, all the way from full treatment, the full shebang, to just certain things, to just comfort measures, and they can go down and all the way down to feeding tubes, no artificial nutrition through feeding tubes. There's a ton of things. So this is what you're looking for, and you will see that they to make sure that they have all that information, they have the signatures that they need to, and that everything looks up to date, and that you're following the directives as best we can. So here's an example of the sheet that you can see, and this is the official one. And still the center we just talked about. So there's also a number of things that we can do when we see some of these patients in various states. Maybe we go there and they're not doing too well, and we can help them. Hey, maybe you need to go get checked out at a or get taken care of at an assisted living because you're kind of having a failure to thrive out here, or maybe you need an actual nursing home. And so a couple big things, and what we'll talk about here is difference between assisted living and nursing homes. There's a pretty wide spectrum. I'm sure you guys have ran on many of the different versions of these. They can, and just because one's assisted living and one's a nursing home doesn't necessarily even equate to the quality of them. There's great nursing homes and really crappy assisted livings, but how it comes down to basically is an assisted living, they assist them kind of throughout the day, make sure they get their meals on time. Sometimes they're very minimalist. They just provide a place where people in similar kind of stage of life can hang out. They don't have too much to worry about. It's basically like dorms, but for elderly folks. To decently assisted living, where they're getting assisted with their meals being brought to them. They're not getting any type of medical care, but they will help them sometimes take their own medications, things like that, and sometimes it's a bit just of social. They have some other ones, and then we get into nursing care, nursing home. Nursing homes is usually when there's some type of medical care that needs to be provided for them, even if it could be very basic, and some of these are really nice too. And there's different areas that are specialties in memory care. There's a few good ones. There's a few bad ones. I'm sure you've all seen some. And there's usually almost always a nurse of an RN at least supervising somewhere, LPNs, and other ones helping, CNAs, and they can be anywhere from very, very nice to not nice at all. I'm sure we tend to run on ones more and that are not very nice. Being said, also walked in on some and just crazy amazing. There's one out in the VA over by Boulder City. It is supposed to be fantastic. So you'll see all types of varying ones, and can be expensive. And you can see even worse ones where it's like the group homes. And if it seems shady enough, feel free to report some of those. The official nursing homes, not as much. Um, Tends to be more of you go there, it's kind of a group home. They have five elderly patients in a room, and they're barely getting any care. And basically, there's like one or two people there just and they just use it to get all the money because you can see how much Medicare will pay for these, and it's anywhere from $8,000 to $9,000 a month. They can be very expensive, and they want to make sure that some of those places are shady. And so, if you see that and it seems inappropriate, please let the nurses at the hospital know, and uh, alert the proper authorities. If I ran on them, you go back, and all of a sudden that house is cleared out because they knew that someone was coming. So remember, we are mandatory reporters. If we see something like elderly abuse, we need to go there. So with that, continue on. So we look at some of the different problems of aging. Tended, oh, in the past 100 years, so our life expectancy's expanded a little bit and gotten longer. Different people age differently. You see some people as they get older, they they're 70 years old and they look 45, and you see other people who are 45 and they look 70. Uh, there's some places that down Boulder Highway and other ones you're like, Vegas did you rough. So we look at that, and some of it's genetics, some of it's lifestyle choices. There's a number of different things that kind of happen, and everyone ages differently, different experiences that happen, and we'll talk about some of these as we go through. So, and different organs can go out with different people, and that can be genetic or lifestyle choices too. So there's a number of different things that can all affect the aging process. So So this is the part where we're going to kind of review many of the stuff that we've kind of already gone over in the past, and a lot of of our other chapters tend to actually focus in on a lot of the elderly issues that we have. Now we're just going to make sure we highlight and and kind of point out different areas that we really that are either specific to the geriatric population or that are possibly different. And so we'll kind of start looking at some of those. So we're going to start out with respiratory because ABCs. All right. Lung tissue generally declines. You're going to notice this throughout many of it, that many of the organs or the tissue themselves start to degrade, decline, and not be function as well as they used to. Some of the things like the arterial partial pressure of oxygen, RPaO2, slowly decreases. However, our arterial carbon dioxide stays the same. This is outside of disease processes too. This is its own just part of the aging process and not necessarily part of COPD or other aging processes with that. The other thing that they'll start to lose is the cilia and the airway. Remember, important thing about the cilia is that it helps get the mucus and other stuff that's foreign objects that are happening in the lungs, not like pennies or anything like that, but like dust, other particles like that, and so they have increased chances of pneumonia and other things. So different things that we have to be aware of on there. Changes that we'll see in the cardiovascular system. The cardiac function tends to decline with age, and it's not necessarily the a disease process either, although that obviously takes a big toll on that, and there is that high incidence of atherosclerotic coronary artery disease. So there'll also be changes in the conduction of the path. That's why it's important for us to take note of how old they are, of the changes that can happen, and then also good for us also to put the age into the EKG to helps or the monitor, because it does help its algorithms if you're using it to help identify any dysrhythmias or alterations. So good things to pay attention to, and some of the things that we'll look over here. As far as renal structure and function goes, that starts to degrade. Nephrons start to be less effective. They have a dysfunction. Just they don't tend to be able to regulate their sodium as well. Sodium, and when sodium doesn't get regulated as well, they're free water in their body, so they don't diurese as well. They don't urinate as well, and they start becoming edemic. The glomerular filtration worsens, and just overall blood flow and fluid flow through the kidneys tends to worsen as they get older. Some other interesting things too, because a lot of medications are removed through the kidneys, that they don't do as well there. And so there's actually a list. It's not on here. Yeah, there it is, the Beers list. And so what it does is it keeps a ongoing list of medications that elderly people don't do as well. Many times we have to lower our dose, go half doses, or otherwise to try and make sure that we don't overdose them or cause damage just because their kidneys aren't able to process it out as much. So we'll talk about a few of those, and here's some of the big ones that are on our in our formulary that we use and we need to be cautious of. So a few of those to include morphine, fentanyl, all the benzos, ketamine, ketorolac, antihistamines, amiodarone, calcium channel blockers, particularly in patients with heart failure, aspirins, corticosteroids, Haldol. There's a few others that we might not have, or CCT might only have, or they might be on at home, and we just got to be cautious. Another thing that will happen, and I can't remember if we talk about it in here, but we've all kind of ran into it where they either forget that they've taken their medication, or they'll take it again, and so they'll accidentally overdose themselves that way as well. And so it's something we have to be alert for all the time, whether we're giving the medication or it's a medication that they're taking at home. Next, we're going to look over the nervous system changes and some mental status changes in general, ALOC type things. In general, intellectual functioning deteriorates a little, kind of in different ways for different people. Like I said from the beginning, neuro is really weird. It can affect everything, and everyone can act a little bit different. There's some disease processes that tend to come with aging, such as Alzheimer's and dementia. We'll talk a little bit about some of those, but there's also some things that can cause people to be, particularly the elderly, to be altered. Different types of metabolic factors, ammonia being all out of whack. Many times it's that urosepsis, sepsis in general, hypoxia, hypovolemia. There's a number of things that can cause people to be altered, and the elderly population is more prone to that. But there's a lot of issues that can come, and that's not even including post-stroke or anything like that, which is also something that can happen. They just many times they just start to not always be there. Some of it's dementia, some of it's some other things. So there's just a number of issues that can cause some dysfunction with people's mental status as they get older. Musculoskeletal issues. Uh, as the body ages, muscles shrink, muscles and ligaments calcify, and sometimes, and particularly as I've said in the past too, postmenopausal females, because they no longer have nearly the amount of hormones that they used to, and the hormones play a pretty big role in calcium and how and bone maintenance. Once those hormones are no longer flowing through the system, they become much more likely to become osteoporotic, which is an issue, particularly when they have falls, and elderly people tend to have falls more. So they also will get some degree of kyphosis as the cartilage in between their spinal cords, the discs, becomes atrophied, and then they have that opportunity to they start to become kyphotic, where their heads are bent forward. And remember, we don't want to try, when it comes to airway or any other issues like that, we don't want to try and straighten those out unless we want to run a code that because we just killed our patient. So we got to be careful with our patients like that, and it's just a difficult airway in general. And they have they don't tend to have quite as much muscles, but they do tend to have a decent amount. They still have some decent weight to them. That their declining neurostatus causes an increased chance of falls. All these things put together, so they have a bigger chance of falling. When they fall, their injuries tend to be much worse. That is some kyphosis right there. Pretty, not nearly as many people have that bad of kyphosis, but that can be due to aging and something that we need to be aware of. So some other physiological changes that kind of happen as folks get older. So about 65 years old, they start losing a bunch of their lean body mass and increase their total adipose tissue or fat tissue as much as 25%. So it's kind of saying earlier that coupled, they lose a lot of the lean mass, they lose a lot of muscle, become osteoporotic, get a little bit more fat tissues on them, and they tend to want, when they become more fall prone to falling, and when they do fall, their bones don't want to hold up much anymore. And so this is where we can see a number of the issues that kind of start arising as everything starts combining. I also don't have a great ability to thermal regulate anymore. Just another thing that just kind of goes away as we age, which can lead to a number of issues, particularly if you have some people that don't want to, they're older, they might be tight on funds, they might not know some of the technology or whatnot, and so they'll not quite recognize that or they will recognize that their house is getting really hot, they don't want to use the AC, and their body isn't able to compensate with that heat very well at all either. So there's a number of issues that start arising. So now we're dealing with heat stroke, even better. They have a decreased immune response, and so they get sicker easy. They have a lot of immunity from over the years, but some of that immunity goes away after a while, and they just have a number of things that start going wrong. So with that decrease in antibodies and their immune system, they have an increased risk for cancer, which is a pretty big issue as we can imagine. And because our immune system constantly gets rid of any cancerous cells that start developing throughout our body, and now if they're not able to do that anymore because the immune system's compromised, we can see how cancer can start being more prevalent in those 65 or older. Also, usually they don't always take good care of themselves, particularly if they live by themselves and they're just not able to anymore. So might not be getting enough vitamins, food, nutrition. They can become depressed, loneliness, decreased sensory taste, appetite, financial difficulties, all these different things that can kind of combine. It's why actually like assisted living as people get older, particularly if they've lost their significant other, can be really beneficial because now they have a sense of community. Someone is making sure they got enough food and nutrients, make sure they're taking their meds. They get to visit other people. So we can see how you can see how assisted living can be pretty beneficial. And then with all these normal physiological changes with aging, if you start adding on some of the chronic or even acute illnesses that happen, it really makes dealing with some of these patients a challenge in the sense that they got a number of comorbidities going on and we have to try and help them and correlate that we know that there's a number of things going on and work through those comorbidities. Sometimes we can't even give the right amount of medications that would normally benefit a patient because we know that their body can't handle it. These patients can be very challenging. It can be somewhat difficult many times trying to get a good patient history from these guys, and just sometimes they are hard of hearing. Sometimes they just have a difficulty getting information out. So, or they don't understand what we're asking. They're poor historians. There's a number of issues that can all kind of arise from here. And so trying to get a good answer to figure out what's going on, as well as they don't feel pain quite the same as we do, right? Those decreased decreased neurological issues kind of show that they might not be able to feel the same pain, which is why chest pain and MIs and stuff sometimes are different in folks that are older. They don't show up the same presentations as they will with those a little bit younger. Always good to check the household around them as well. Make sure everything seems like they are, if it's at their house and they're by themselves, that they're taking care of themselves and they're able to take care of themselves. There's a saying that failure to thrive. It's not anything bad necessarily in the sense that they're a failure or anything, but at a certain time, we have to, if they're not able to take care of themselves and not able to thrive by themselves, then we have to try and find a better place. And that's where it's a big, the hospital doesn't always recognize that. So us as EMS providers need to kind of pass that along and tell them, hey, this is a little bit of failure to thrive at their house. They just weren't taking care of themselves. This is the second time this week we've uh, gone over there. And so there's things to definitely think about when we're seeing these patients. So that, go on to the next one. So we're going to start looking at the dealing with some of the very specific illnesses that come along, and not just the aging process itself, but that kind they'll have these illnesses, and how, what we're going to look at now is how those illnesses affect the aging body and things that we need to be aware of for specific ones. We're going to first start out with cognitive function. Impaired cognition is found, and is found as many as 10% of older adults. Sometimes it seems more than that, right? So just due to aging or due to any number of the factors that we kind of already talked about, they already have that without any type of acute neurological issues. Pulmonary system, we talked that they already, because they have that decreased lung function, including the decreased amount of cilia, they have a much higher chance for bacterial pneumonia and COPD, whether they smoked or not, although we know when they do smoke, it definitely increases their chances. And about 85 of all pneumonia and influenza deaths occur in patients that are 65 and older, right? They get sick, and because they don't have any compensate, they're not able to compensate, and they're not able to deal with these sicknesses nearly as much. They're much more prone to increased morbidity and mortality. Typically, kind of the same that we'd see normally with the bacterial pneumonia. Productive cough, dyspnea, pleurisy, chest pain, sweating, signs of pulmonary congestion, but they may all be absent or not, and it might not be as obvious in some of our geriatric patients because they, particularly the cough, they may not be able to cough itself and produce a sputum to get rid of that what's in their lungs, and they don't have the cilia to help it out, so they don't have the ability to cough or naturally kind of get rid of the the foreign objects in their lungs. So COPD. So COPD in geriatric patient, it's a huge issue. We already know they have a number of issues going on with their lungs, not able to compensate well. They're not able to get rid of mucus, and COPD is it can, particularly the chronic bronchitis side has a big issue with too much mucus. So now they even have more in there. Many times to develop COPD, it takes until people are in their older by the time it kicks in, and so by then now it's just it's an issue that we chronically see in there, and now they're having to deal with having to have oxygen at home sometimes, or having all these other comorbidities, And then if you add anything else, like any other normal aging issues, it just makes everything that much worse. Cardiovascular systems, we're going to just kind of review some of the ones that we'll see. And many times we do see these primarily even in geriatric patients in general, right? So like our MI or heart failure, typically those we see either in the definite geriatric phase of like 65 or older, but we see it a little bit younger too. Sometimes when we see it in that 45 to 50 age, they'll have their first MI there, and then they'll develop the CHF, which they'll have later on in their life, right? Dysrhythmias, as those electrical pathways change throughout the heart, just due to age and cellular and organ breakdown, we start getting just dysrhythmias as some of those electrical pathways then show or cause different dysrhythmias. Big one that we see chronically is AFib, right? And abdominal and thoracic aneurysms, when we see those, get that atherosclerosis, particularly in our aorta, if they have hypertension for a long part of their lives, a lot of that can cause damage to the aorta and causes just these that it takes a chronically long time to get there, but when they do get there, then now they have these issues that they need to that finally start coming to head, and now we're dealing with the AAA or interthoracic uh, aneurysm. And hypertension is always tends to be an issue, right? It's not an acute emergency, but man, is it a chronic emergency, urgency, I should say. And typically we see chest pain less common as a symptoms. Like I said, saying a little bit like a few back is that because pain is felt less or differently due to some of those neurological changes in like the pain nerves, um, they don't present necessarily the same, particularly the older they get. And we got to be aware of that. Many times they also, if they've already had cardiac issues, their body too will rewire their circulatory around their heart, and so if their second or third MI actually might not kill them, where normally it would have killed them if that big MI would have, but they develop those alternate pathways for blood to get through their heart. Being said, it doesn't show quite the same on the EKG, and it doesn't present the same as far as pain and presentation goes as well. So we will have some geriatric patients that present kind of typically, but then you'll get the ones that don't. Women tend to be a little bit more have different presentations. They won't necessarily complain it. They might be non-specific, just weakness, maybe some shortness of breath, sharp pain instead of a pressure, just fatigue, things like that. And 85 years or older, and they get really atypical, and some of it's just really hard to point out what they do because it can be different in between the different patients. It's not as typical as we see in our younger patients. By younger, it's our 40, 45, 50-year olds. So got all that. So heart failure in general is the leading cause of hospitalizations for people age 65 and older. Although I think we've all kind of learned that heart failure is somewhat generic, can be used somewhat generically, and that yeah, their heart failed for whatever reason. Usually many things fail throughout our lives. However, when our heart fails, we tend to die or get, if it's just not completely arrested, become really ill because now we can't circulate our blood and it becomes a pretty big issue, right? So that's why heart failure is always labeled as one of the leading causes of death. Um, Usually many times there's other things involved, but heart failure is almost always. And for the patients that have high blood pressure, that risk just it doubles. So things to be considered about, as well as diabetes mellitus, because hypertension usually follows, and myocardial infarction, right? So just to review heart failure is leading cause of hospitalization for people living 65 and contributes to about 5% of all emergency hospital admissions, occurs when one or both ventricles cannot pump effectively, CHF, get the backup of fluid into the lungs and third space and into our body. Um, and so something we just need to be, we know it's a big issue. That's why we go over it so much in class. Arrhythmias, typically a common cause of it is hypertensive heart disease and other big issues that we can have. Weakness that comes and then falls. Then they'll have the cerebral hyperperfusion, TIAs, and heart failure. So there's a number of things that we need to be aware of. So when we're talking about abdominal thoracic aneurysms, like I said, we get that atherosclerotic disease and kind of hits in it caught over as they get older, their aorta becomes more rigid, more sclerotic, and is more prone to aneurysms, dissections, and all that life-ending horribleness. So our goals with these, with any AAA, gentle handling. If we know that you're having your partner drive super slow, if there's a pothole, you're avoiding at all costs. Speed bumps, you're going over half mile an hour. You don't want to cause that to blow. Even if that AAA tends to burst in the ER or even the ambulance bay, anywhere in there, not much they can do. The best chance they have is if something happens if they're on the surgery table, and even then, not guaranteed. So we got to be super gentle with these guys. Just some of the same common symptoms that we see. The pulsating mass in the abdomen, thoracic, we're not really going to be able to tell. We're just going to hope it does. So hypertension, many geriatric patients end up with hypertension and have atherosclerosis, and hypertension are pretty common disease process that both the elderly geriatric patients have, as well as they are comorbidities many times. And as a reminder, what hypertension is, blood pressure consistent greater than 130/80. And a crisis is when it's 180/120 or more. Once again, it's still not necessarily an emergency that moment. They need to get it down, but it's that chronic always having it up that they really need to. Many times when you see someone with that 180/120, they will still usually be sent home if there's no other comorbidities, and they'll be given meds and they're going to slowly lower it. They typically don't want to lower blood pressure too quickly. They're going to lower it over a set amount over a little bit of time. Some nervous system pathophysiologies that we are dealing with outside of the normal aging. Uh, Many of them can cause that cognitive impairment, and it's it significantly affects their life. Typically, when you get some of the bad ones, we're talking about like dementia, Alzheimer's, any post-stroke, or stroke as it happens, obviously. Um, some of it will know just have that cognitive impairment. Some of they don't always know, but it's just that degradation of cellular tissue and other issues that are kind of going on throughout. So they'll have the cerebral vascular disease, delirium, dementia. Remember, delirium is in the acute phase, dementia is in the chronic. Alzheimer's is a form of dementia that has its own things, and then there's Parkinson's disease. So stroke's the leading cause of death in the United States. It's not the leading cause. Usually death falls to heart failure, as I was kind of talking about earlier. However, neurological impairments caused by, as we've talked about in the past, ischemic or hemorrhagic interruption in blood flow to the brain. So it's either a clot or a bleed. And with that, so we have, you'll notice a bunch of these associated risk factors are almost all things that geriatric patients have. One of the big, outside of the diabetes mellitus, but the rest of them being atherosclerosis, hyperlipidemia, polycythemia, heart disease, all these things that these patients tend to, or the geriatric population tends to get, they then have as a risk factor for stroke, which is why we see so many strokes in the older population and not nearly as many in the younger. We still see them, particularly some spontaneous aneurysms, and you do get thrombolytic strokes in younger populations too. But it's why it's so prevalent in the older population, because they just have all these comorbidities that add up and cause and have stroke be a pretty devastating and prevalent uh, pathophysiology that happens. So we can see that over three-fourths of people who had a stroke have had high blood pressure greater than 140 over 90, and smoking doubles that risk. It'll be interesting to see where things are at in a few years as smoking's really gone out of vogue and vaping's on. Probably more lung disease, a little bit less hypertension and stroke type things, but we'll see. Uh, Another thing that's interesting is that 4 out of 10 people that had a stroke will have another one in 10 years if they survive that. That's almost half the people that had one stroke will have a second stroke. So pretty big thing there too. Deficits. Many of you guys had seen as we pick up some of these patients from the rehabs and long-term care facilities that they'll have these devastating neurological deficits. That kind of shows the importance of us getting them to the right location in a timely manner, and for them to recognize that they're having a stroke, or have someone recognize that they're the person that they're with is having a stroke, and getting 911 activated and getting them to definitive care, because they can be absolutely devastating, and it's definitely something we need to be concerned of. All right, so as I was kind of mentioning earlier, delirium is, there's basically two sets of confusion. There's ALOC, in particular in the geriatric population. We have delirium, which is acute, and it's an abrupt onset of confusion, and attention disorder thinking, altermentation, because of a medical condition that has the potential to be reversed. So that's going to be a little bit different than what we're about to see for the dementia, which is more of a permanent, long-term, chronic issue. It's not always permanent, but it tends to be. So things to be looking out for in delirium. It's I watch death is another acronym. Infection, withdrawal, could be from alcohol, could be with drugs, could be from their own medications, a number of things. Acute metabolic issues, pneumonia is a huge one. Trauma, fall and hit their head, or hypotension. CNS problem, hypoxia, deficiencies, endocrine causes all types of weird things, right? Acute vascular issues, toxins, and heavy metals. Acute vascular be cardiac and or stroke. Delirium can be life-threatening, requires emergency care. Another big thing that happens with delirium is that delirium can be caused by that lack of blood flow to the brain. So having that is something that we need to be aware of, and we need to try and fix that. It's always a good question. When did this onset? Are they normally like this? Dementia is a loss of intellectual functions such as thinking, remembering, reasoning, sufficient severity to interfere with the parent's daily functioning. Can be difficult to differentiate from delirium in the pre-hospital setting. So once again, ask the family, bystanders, anyone else, what are they like normally? What's different? And so we can try and get that different neuro assessment. It might seem like it might be delirium at first, but it's just moving from delirium more to a dementia state. But we still got to try and see if there's a difference. And many times that's the hospital's not going to be able to tell, but we can investigate in the field and figure some of this out. Alzheimer's is a specific disease process within it's a dementia, but it's a more specific um, subset of disorders. So some of the characteristics of Alzheimer's being its nerve cells in the cerebral cortex die and the brain substance shrinks. They're not exactly sure what all of it is. There's some genetic links. They're not all entirely sure. There's a couple different kind of subsets of Alzheimer's as well, and some early signs and symptoms would be related to memory loss, inability to make or recall new memories, and there's no disease treatment process for Alzheimer's. So it's a decently devastating disease because people lose who they were, and it can be devastating both to the patient and to the family as well. So it's something to be aware of and try and see if there's any familial history if we're looking at that. Vascular dementia is a reduction in cognitive function caused by conditions that block or reduce circulation in the brain, stroke, or even just any type of lack of blood flow to that brain. Progressive decline of cognition related to multiple minor strokes, changes from minor to severe, and memory loss may or may not be significant symptoms. Parkinson's disease dementia, average onset of Parkinson's developing dementia is about 10 years. Approximately 60,000 Americans are diagnosed each year. It's another subset of dementia, something to should be aware of. Lewy body disease dementia occurs in patients who have abnormal deposits of protein called alpha-synuclein in their brains. Initially misdiagnosed with Parkinson's, the signs and symptoms of Lewy body dementia that distinguish from Alzheimer's are motor symptoms and hallucinations early in the disease and a fluctuating mental status. Frontal lobe dementia. This type of dementia can results from the frontal temporal lobes, hence why it's what it is. Group of disorders caused by progressive nerve cell loss in the brain's frontal lobes, fairly intact memory but struggles to plan or make decisions. Often begins around age 50 or 60, but may not occur to patients in their 80s. Three primary types, and patients may experience weakness, trouble walking, falls, and incoordination. All right, some issues with the endocrine system. Two of the most common we'll see are diabetes mellitus type 2 and thyroid disease. Talked about diabetes in the past, but we'll just do a quick review. About 25% of adults older than 60 have diabetes. Often occurs when hyperglycemia is found during blood. Combination of dietary measures, weight reduction, oral hypoglycemic agents such as metformin, and in some cases insulin can keep type 2 under control. HNS, or hyperglycemic hypermolecular state, is a serious complication that occurs. And another reason that hypertension follows, particularly both type 1 and type 2, is that because sugar molecules are really big, it follows the osmotic pressure that fluid and plasma stays in the circulatory system. By having that increased amount of fluid in the circulatory system, and that increased osmotic pressure is going to increase the blood pressure as well. Hypothyroidism, it's very common and just destruction from the thyroid issue. Emergency care is mainly supportive. GI systems, it can be a number of things: GERD, peptic ulcer, diverticulitis, and cancers. Big one that we got to be concerned about is GI bleeds. Many times it's very difficult to find them, and they have to endoscope either from the top or the bottom, or sometimes both. There can be problems with continence, either being incontinent or being constipated, and problems elimination. So constipation. GI hemorrhage, huge issue, particularly over time, and this is the ones where we're really trying to figure out whether it is coffee ground, being upper GI bleed that gets digested, or Tari stools, lower GI bleed that didn't get digested. And so just kind of looking at different areas where it is, and sometimes weakness, agitation, syncope, jaundice, constipation, diarrhea. Then we also have for our liver damage patients where we get the backup of blood, and we'll get into some more of that here in a minute. Bowel obstruction generally occurs with patients prior abdominal surgeries or hernias. Our care is mainly supportive. Incontinence, inability to control the bladder or bowel function, urinary incontinence can vary in severity and sometimes can be a smaller, bigger issue. And bowel incontinence is usually often the result of fecal impactation. Incontinence is embarrassing for everybody. Elimination, cause of difficulty urinary results from enlargement of the prostate for men, UTIs, urethral strictures, and acute or chronic kidney failure. And kidney failure is a pretty big issue overall because then there goes all our electrolytes. So all these are pretty big issues, and you'll see a lot of altered mental status as well come from UTIs or other kidney issues because if kidneys aren't working well, then our electrolytes get out of balance. We're not able to eliminate and uh, moderate different molecules within our body, include like ammonia and other. So skin, skin becomes dry, transparent, and wrinkled. It no longer has that elasticity. Be very careful. If they ask you to use a better tape, please use a better tape so you don't rip their skin. They don't heal very well either. So it's rather important to try and do some of these things and be cautious with our patients. Pressure ulcers, pretty big deal, particularly with our patients that aren't very active or are not able to be active due to some type of neurodeficit or just as they get older. And it's very common in our geriatric patients. It's something we need to definitely be concerned about. And we need to be looking particularly for our patients from our nursing homes and long-term care facilities. It's resulting from tissue hypoxia related to pressure. There's blood is not able to get through there and provide oxygen to the tissues and circulation to the tissues, so then it becomes necrotic and dead, and then it gets worse and worse. So we need to be careful with that. Osteoarthritis, we talked about some of this back a couple times now, so I'm not going to spend too much time on here. And same with yeah, osteoarthritis. You've seen, I think, this exact picture before. Sensory impairments, uh, many times, as I was mentioning earlier, that they are unable to talk, or if they're unable to listen, sometimes they're unable to see. Other times, if you, sometimes it's worth an extra couple minutes. Grab it. If they have hearing aids, grabbing them and giving it to them, so then you're not yelling at your patient and having any misunderstandings. It just makes everything easier. Glass is always good. Speech, sometimes they can have a difficulty speaking. Sometimes, once again, the teeth, if they have their teeth in, it allows them to be able to speak much clearer and better. We'll have two different type of eye conditions, cataracts and glaucoma. Cataracts lacks a loss of transparency of the lens of the eye, and glaucoma is when we have an increased intraocular pressure. So a little bit of difference there. They can kind of look a little bit the same just from an outward appearance, but it all has to do with a cataract just has that clouded lens, which is in that right behind the cornea. And then for glaucoma, it's increased intraocular pressure in the virtuous body. So we get this increased pressure in there, and that's what causes the issue. So it's a little bit different issues, and we're a little bit more concerned with patients with glaucoma than we are necessarily with patients with cataracts. Other than the fact that they can't see, but when particularly with certain medications we would want to give and whatnot, we don't want to increase intraocular pressure. Not all geriatric patients have hearing loss. There's also things like tinnitus, which most of us have had after listening to the siren go off for so long without wearing proper hearing protection, or if you like been around place things where things are blown up a lot, gunshots, all those things tend to use you lose tonight or you hear have tinnitus. That tinnitus ringing in the ears is usually the last time you'll ever hear that exact tiny tone, because that is the cilia in your ears no longer wanting dying and you're not able to hear. All right, now on to toxicology. As I was mentioned earlier, due to their inability to deal with to process and detox certain medications, they have a increased risk for adverse drug reactions, as well as just other reasons that they don't, just due to the aging process. Some of it include gastric pH and GI motility. Sometimes, like I was mentioning earlier, the accidents. Oops, I forgot. I left this. They forgot to take their meds, or they took too many of them. There's a number of different issues. Many times they have multiple physicians all giving medications and they're not checking each other, and so they have weird drug interactions. And because they're on more medications than the average person is, because of all the issues that they get as they get older, we can see how this can become a problem. Many times they'll also become have substance abuse issues. Some of it's because they have nothing else to do during the day because they're no longer working, they're no longer doing things, and so they'll drink or they'll do whatever else. So they'll actually have elderly people with substance abuse issues. We can ask the family to see if they think it's an issue, because we can always look for ways that we can try and help them and get them social care after the medical emergency is over. I think I mentioned this earlier too many times, is at places such like their house, whether they might have financial issues where they're not able to keep their house at a good temperature. In Vegas, we see more on the heat side, but many places in the country they'll see it on the cold side where they don't keep their house warm enough. And whether it's a financial issue, whether it's an issue of how they were raised, but they don't always feel temperatures nearly as well, and then they aren't able to thermoregulate, so they are much more. And then because they're not able to thermoregulate, they're at much higher risk for heat stroke or hypothermia, depending on whichever situation they're in, where they live many times. Where they're more often at risk than younger people for hypothermia, and many times it's because of socioeconomic factors, whether that's the money itself or just the social or raising aspect. Sometimes we don't see them quite as much anymore, but many people from the Great Depression that grew up then, very frugal, and they don't want to spend money on, they think they can tough it out because they did when they're younger, but because they have this increased frailty of their bodies, they don't tolerate it as well. So it's definitely something we need to be on the lookout for. Uh, might be less likely than many places, and you still will, but in particular in Las Vegas and in the summer, or many other areas in the Southwest, hyperthermia is definitely an issue, particularly if their AC's out of the house, they're trying to keep it really warm. This is where we see the hypothermia more. We don't see hypothermia as much here. We still do. Not we tend to see hyperthermia more. They estimate that approximately 1/5 of people older than 55 have some type of psychiatric issue and are mental health concerns. Some of it might just be depression and them trying to deal with it. They could be looking at end of life issues. There's a number of factors that can go in. Losing their significant other over the from that might have passed before them, or just having lost that goal in life that work might have brought them, and so they'll be in a number of they can have a number of mental issues. There's actually and elderly suicide is a pretty big issue. 18% is a pretty large number for the total population, and some of it's just that they'll just want to go out on their own terms. They might have other issues that are chronic that they don't necessarily want to deal with, or that some of their health issues have then led to them have mental issues as well. And so there's no evidence that asking person questions about this increases risk. We should ask about them, and most suicides involve firearms. Trauma is the sixth leading cause of death for people older than 65, and 1 in 4 Americans older than 65 falls each year. Yeah, I think we run on most of those, right? So fractures are the most common fall-related injuries, and the hip being the fracture that most often results in hospitalization. Many times these can be very, very active people, no problems. They are going about life, just doing everything great, and they'll break their hip, and it'll be so debilitating, and they'll become so sedimentary that they will then their health will decline rapidly, and many of them die after a couple years after a broken hip from just a number of the complications that come with it. And it's usually the hip is usually around the neck of the femur when it happens most often. They're trying to reduce falls. That's why falls in hospitals are such a huge issue, and they need to document things like that. And uh, getting handrails. There's a bunch of important things that they can try and do to try and help with the home life. And some of it just might be moving to an assisted living, things like that. Vehicular trauma. More than 40 million licensed drivers are older than 65. Older patients have increased morbidity and mortality and sustain more severe injuries just because they're not able to handle it as much. And then they also have issues like the aging. They don't have as quick reflexes anymore. They can't see as much. They have there's glaucoma. Their eyesight starts to go. There's a number of issues that all start to happen as they get older that makes driving at risk, as well as having some type of medical issue while they're driving, which can then lead to an accident. More than 1,200 adults die each year from burns. Yep, happens to have more. Bigger one that we see a lot though is head trauma, and because they'll fall many times, also as they get older, their brain shrinks a little bit, it atrophies, and the vessels between the meninges and the brain will stretch, and a fall will cause them to break. Many times we see these as subdural hematomas, but they will have every type of bleed that there is. You'll have the epidurals from the arterial bleeds, subdurals for the venous, and they'll have intraperitoneals and subarachnoids as well. Chest injuries. Here's some ones. Hopefully, we've seen some of this in the past, but this is aortic injuries again. This is actually talking more about on the aortic aneurysms. It can be dissection. So there's a couple ways that they'll classify these. They'll classify them either as Stanford or DeBakey's. Very similar, and it just has to do with what part of the aorta is injured, whether it's part of the ascending, descending, both, the arch by itself, and or the abdominal, right? And so I would not necessarily have to memorize this. If you ever do CCT, you'll have to know a little bit more about it. But in general, so type A's for the Stanfords is the same as a DeBakey type 1 or type 2, and it has to do with kind of it has to do with the arch itself and the ascending. And a type B or type 3, type B on Stanford or DeBakey type 3 is going to be having to do with the descending. The type 1 DeBakey has the whole thing though. Yeah, we did this already. So how we're treating these patients, be aware, do a 12 leads. If there's anything, weakness, shortness of breath, just get on top of that quickly. We talk about issues when we're not getting circulatory, if you guys remember. They aren't able to compensate as much, and usually and so how acute kidney injury will happen in this case of hypovolemia is the body starts shunting. And if you guys remember, the kidneys are one of the last ones to outside of our core, heart, lungs, brain, that get shut off when there's a lack of blood. And when they do, kidneys are very, very, very reliant on blood flow and plasma flow through them. And when they aren't getting enough, they start to, or you get your acute kidney injury, and then we're not able to regulate our sodium, potassium very much, and so we get all types of injuries with that. Don't overhydrate them. Be aware that their kidneys probably aren't going to work quite as well, and that they're so we don't want to cause them to become edemic, whether it's pulmonary or in their limbs. Sorry, my brain just stopped. Older adults, obviously, they're more susceptible to it. Hypovolemia and hypotension are poorly tolerated because they don't have those compensatory mechanisms anymore. Kind of like pediatrics, where they just they can different but kind of similar. It's why it's always either old people or little kids, because kids can compensate for it really well for a short time, but then they run out. They don't have the stores, and elderly geriatric patients aren't able to compensate anymore because those compensation mechanisms in their body aren't working as well or at all anymore. And consider them hypovolemic if their blood pressure is less than 120. And tachycardia may be blunted or may not occur if they're on beta blockers. I think we've gone over this quite a lot through scenarios and in the past talking about things. So with that, just be aware. Sometimes they might not look in shock, even though they're rather shocky, just because they're not tacky. Tachypnea they can still show signs of tachypnea, and because that could be blunted a bit as well, but that's another way that we can look at for some shock. So respiratory system assessment, things that we need to be worried about. They have less lung elastic recoil, smaller airway calibers. They have less expiratory flow, and they are much more prone to dynamic airway collapse. They typically have less chest wall compliance and less respiratory muscle strength. All that comes down to they have less gas exchange, and their respiratory drive kind of sucks. And system sucks. So we need to be ready to support them sooner. They're going to get tired of uh, of breathing of labored breathing sooner, and they aren't going to be able to do it as long, and we need to be able to help them breathe, whether it's through medications, positive pressure ventilations, or intubation if we need to. Remember, positive pressure ventilations can be BVM and or CPAP or RIPAP. COPD, we kind of know how to treat these. Um, we know they're dealing with their hypoxic drive, so they're going off oxygen instead of CO2 in their blood many times on the COPD patients, and so uh, be cautious with high flow O2. That's why we don't throw high flow O2 on everybody. Um, but if they are short of breath and they are having a hard time breathing, then them not breathing is going to cause more issues than that hypoxic drive getting knocked out. So, yep, talk about all these. They have a decreased ability to maintain that acid base balance and compensate for fluid changes, whether that's too much fluid or not enough fluid. And if they have any type of kidney disease along with that, it's going to be even worse. So be cautious of their fluids. 250 to 500 boluses is usually a safe bet. Transport strategies, particularly with patients that are kyphotic or have other issues, lots of padding and pillows is very helpful and can be very beneficial. Don't forget to warm our patients. Remember, they have a hard time and they have a not great working thermoregulation system. Elder abuse is a pretty big issue sometimes. I mentioned it a little bit earlier, but we need to be concerned about it, and we need to make sure that if we see anything or we have any suspicion, they are a protected class, and we are mandatory reporters. So if we see something, we are obligated to tell someone, and required to, as well as like we should, and we might be the only people that can really stand up for these and see it as it happens. So we need to be on top of that, and if we see that, try and help these patients, because many times no, we're going to be the only ones who really recognize that. And if nothing else, it's just a quick let the hospital know. You'll let the charge nurse know that you suspect elderly abuse. You might have to fill out a paperwork or something, most likely, but they'll further the rest of the investigation. So we need to make sure we're doing on that. The abuse can take many forms: physical abuse, sexual, emotional, psychological, neglect, financial, material. Um, we're all mandatory reporters, every single state in the nation. All right, guys, any questions on that? If you do, sign up. This is a long slide. I have a quick other ones on the next profession that we're going to look at in hospital profession. So, nurse practitioner, we're going to look at this. You must be a registered nurse and hold a bachelor's in nursing, and then complete a NP focused master's or graduate doctoral nursing program and successfully pass a national NP board certification exam. NPs are classified as advanced practice registered nurses, APRNs. It's what you see, particularly in Spring Valley and the Valley Health System. They'll have APRN. They'll have that as opposed to necessarily NP, FNP, DNP. Those are all different types. I'll talk about a few of them. DNP is the doctoral nurse practitioner. The only ones you might see different is a CRNA, and that'll be, although they could have APRNs, but CRNA is the certified nurse, registered nurse anesthesiast, and there's a couple other specialty ones, like I said, nurse midwives and clinical nurse specialists. As they go to these schools, they pick up all those crazy specialties and they get really good. NPs are, they can prescribe meds, they can do all types of super interesting things. It's the roughly the equivalent of a PA, but they have some things that they can do that PAs cannot. So, journey to become how they get to be nurse practitioners. So, they'll get their BSN, they'll pass their NCLEX, enroll in a graduate program, and then pass the board. There's all these details. The Masters of Science in Nursing, they'll build more on that. The DMPs, they're becoming more and more, particularly because NPs have independent practice, which is a pretty interesting thing where they don't need, after, I think in Nevada, it's after 2 years of working as an NP, they no longer have to work under a doctor. They have their own license to prescribe their meds. They have their own DEA number, all that stuff. So, some cool things there. So, some of the things that they can, and they will many times specialize in some of these. Um, and so, some of these that we'll talk, that they'll have these crazy acronyms. Adult gerontology acute care nurse practitioner, of where they know particularly whether they're specializing in pediatrics, geriatrics, or adults, and or elderlies. Then there's FMPs, which is what you see a lot of times. That's what many people or NPs end up getting, and even if they're working in the hospitals, not really as an FMP main job, but that's the specialty that they started out with, and it's just a family nurse practitioner. Uh, but as more and more, as NPs are used more and more of these advanced care practitioners, such as PAs, are used more, they're finding more and more specialties, and you're going to have some more schools that specialize in certain areas. Neonatal NPs and NMPs, they do really well. And when we did our neonatal care and rotations in there, they had as much say in the care of these neonates as the neonatologist, the doctor, and they are very good at what they do. They're very specialized, and that's all they do, but they're really good at it. So, and you'll usually see them in the NICU. Pediatric NPs, PNPs, all the way from newborns to toddlers, adolescents, young adults. You'll see them in pediatric ERs, ICUs, all those. So, and or psychiatric mental health, women's health, mental health. So these are some of the specialties. So NP pays. How much they pay? California, they'll start out, and this is just general NPs. We're not getting into even the advance of CRNAs. They are their own specialty that make a ridiculous amount more. But in California, they started out averaging at 158,000 a year, pretty decent. New Jersey 143. Nevada is fifth highest in the nation at 136, and it seems pretty average. And you can, there's one of my friends, her friend that got her N2 DMP. Um, she's making well in the 200s at a HCA hospital. So they make a ton of money. And depending on the specialty is will definitely help depend on how much they make overall. So now to get to CRNAs, certified registered nurse anesthesiast. First, they need a BSN. After the BSN, they'll attend an accredited nurse anesthesia program, either a master's or doctorate. By 2025, they're all going to have doctorates. It's while it's a lot, it's not quite the same as going to med school. So they'll do their 2 or 3 years, and then they get out with a doctorate. Call them doctor, not MDs, and they the average cost is 35 to 60. That doesn't seem quite right, but it seems like it should be higher. Being said, it's once you have your if you have your BSN, it's not a big step after that. They're definitely the highest paid nursing job, and for good reason. They do a ton for you guys that have gone to the OR and dealt with them. They do great. They're super friendly to us too. They tend to be more friendly than the anesthesiologist. Anesthesiologists are usually some of the highest paid in the hospital as well. But the average nurse anesthesiologist salary is 195, and they are APRNs, like I was saying. And what they do a number of different things. They receiving and recovering anesthesia. They put people on anesthesia, they tube them, and they do all the fun things that anesthesiologists do. Uh, they have almost the same scope, but they work underneath a anesthesiologist, and they have a ton. One big thing that from what I've talked to, is most CRNA programs you're not allowed to work while you're in that program, so you build up a lot of student loans unless you can somehow pay for the school and live off it by yourself. But afterwards, you make that pay up rather rapidly, and yeah, that's usually the start. Or I guess that's an average pay, but it definitely gets higher. They're usually almost always some of the highest non-doctor, and they make more than many doctors. Educational, 1 year experience working in an ICU unit, but usually 2 or 2.5 years of ICU experiences. CV ICU, cardiovascular ICU, cardiothoracic ICU, medical ICU, surgical ICU, burn trauma ICU, neuro ICU, PICU, or pediatric ICU. You don't see NICU nurses in here really because that's not necessarily a thing. But they'll take 2 to 3 years and provide both high level classroom work and clinical practice, fully in person, but there's a few hybrid systems. So apparently that's it.